Hi, my name's Carlin, and I'm reviewing Alzheimer's and exercise. Let's get started. To start, I'd like to go over some background about Alzheimer's. So, Alzheimer's is a progressive neurodegenerative disease that impairs memory and cognitive judgment. It's one of the leading causes of dementia in late adult life, and it accounts for 60 to 80% of cases. As of 2018, there were around 47 million people with dementia worldwide, which is expected to triple by 2050. So, studying the potential treatments for Alzheimer's disease is incredibly imperative for the future of healthcare. There are various signs and symptoms of this disease that can be seen in the brain and in the body. One of these is a higher risk of falls and fractures, and declining mobility, and in general, declining functioning. We also can see cell death and brain atrophy in the hippocampus, which is affected early on in Alzheimer's. And the hippocampus is incredibly important for episodic memory, which can help explain why there are so many memory issues with this disease. We can also see a presence of neurofibrillary tangles and amyloid beta plaques in the brain. And of course, with anything, symptoms vary and the degree varies among individuals. So what's commonly seen are worsening memory, severe memory loss, and neuropsychiatric issues such as depression. The current treatment for Alzheimer's disease is focused on pharmacological treatments. These treatments are specifically targeted at symptom relief, and the way these work is that they modulate the acetylcholine or glutamate activity in the brain. However, none of these treatments have been shown to significantly slow down the disease. And of course, they come with side effects. And cognitive training and cognitive stimulation have been explored as treatment options, but they have also shown mixed or inconsistent benefits. And of course, there's no cure for the disease yet. So, there currently is no treatment that is effective and has no side effects. So, what about exercise? Studies that emphasize the importance of exercise exist, but the effects on cognitive functions in Alzheimer's patients are mixed. Some studies have observed no positive effect of physical activity on cognitive function, while others have. Exercise has posed significant improvements in attention and processing speed, executive function, and memory improvement in exercise groups of the non-demented older adults. Exercise has been effective at reducing cortical decay in the elderly, and there has been observed associations between better fitness levels, larger hippocampal volume, and better spatial memory for active individuals. So, if there are obvious benefits seen in non-demented older adults, you would think that there would be benefits seen in adults with Alzheimer's too. Luckily, exercise appears to have potential benefits on those diagnosed with Alzheimer's disease. There are possible improvements in cognitive function, decreased neuropsychiatric symptoms, and a slower decline in activities of daily living, which has been seen in Alzheimer's patients. So, exercise is promising. Let's go through some of the proven and potential benefits of exercise. Exercise may help with depression, which is one of the most frequent comorbid psychiatric disorders in Alzheimer's. Exercise is also associated with a higher hippocampal volume, enhancement in functional capacities, and personal development. And as I mentioned in a previous slide, the hippocampus is important for memory and is largely affected by Alzheimer's. Aerobic type training might slow brain atrophy, which is important for neurogenesis, synaptogenesis, and neurotransmission. Aerobic training might also slow down the production of amyloid beta plaques, which is a hallmark of Alzheimer's disease, as I had mentioned earlier. In addition, physical activity and social interactions may affect brain-derived neurotrophic factor, or BDNF. BDNF is a growing and survival factor that regulates the development and maintenance of neurons. It also aids in control of the synaptic function. So, BDNF is an important mediator of the memory processes, synaptic transmission, and brain plasticity. So let's dive into some studies. This randomized controlled trial analyzed the effects of continuous and interval aerobic training on plasma BDNF levels, aerobic fitness parameters, walking capacity, cognitive performance, and quality of life in seniors with mild to moderate Alzheimer's. There were 3 groups: a control group, a continuous aerobic training group, and an interval aerobic training group. The participants had to be 60 and over, functionally independent, able to exercise at moderate to high intensity levels on cycle ergometers, and diagnosed with mild to moderate Alzheimer's. So the group breakdown, there were 14 in the continuous group, 17 in the interval group, and 21 controls. The average age was 78 years old, and the maximum age was 96. This graphic shows the timeline of the study on the right. So specialists collected the primary outcomes, which were the plasma BDNF, and secondary outcomes, which were the aerobic fitness parameters, functional capacities, cognitive functions, and quality of life. All study outcomes were measured and collected blind at baseline, and then after the 9-week intervention, and then again after a 4-week post-intervention. So the study looked at functional capacity, which was measured with the total distance in a 6-minute walking test. Cognitive performance was measured with the standard mini mental state examination, or MMSE, which will be used in the next study that I'll talk about. Then there was a quality of life assessment, and aerobic fitness was measured with IMET, and IMET stands for Incremental Maximal Exercise Test, which were delivered at the beginning and the end of the intervention. For the continuous exercise group and the interval exercise group, the workloads were determined with heart rate max, which was measured with the IMET and considered to set the initial intensity target values for the first training sessions. And these, of course, were reevaluated to maintain the prescribed intensity if needed. So that both of the exercise groups exercised on cycle ergometers. The continuous group exercised for 30 minutes, and the interval group also exercised for 30 minutes, but with 6 intervals with 4 minutes at the base and 1 minute at 80% maximal heart rate. Once a week, additionally, the controls attended 30-minute sessions detailing health benefits of physical activity in seniors, which was structured with discussions around multiple choice questionnaires. So let's check out these results. First, I want to go over some of the limitations of the study. So the use of percent heart rate max for exercise based on global recommendations in ACSM may not have been sufficiently intense to induce a significant effect on plasma BDNF production. The BDNF response to aerobic training may also be affected by individual level factors which were not controlled for, such as genetic factors. This study also had a small sample size, which limited the ability to detect significant differences in BDNF response, and BDNF may not actually be a useful marker for cognitive status, and there could be a delayed response between a change in BDNF levels and improvement in cognitive performance. Let's look at the actual results. The study unfortunately found no significant plasma BDNF response to exercise in either group, and no significant improvements in cognitive performance. But training did improve aerobic fitness and functional capacities, which indicates an increased maintenance of functional independence to perform activities of daily living. And this is huge. The ability to perform ADLs progressively declines with this disease. So if exercise can help slow the decline of ADLs, then exercise can help Alzheimer's. The continuous aerobics training group also showed benefits of quality of life, which indicates a key role of aerobic exercise to favor social interaction and improve mood and self-esteem. This also links with the depression aspect of the disease. So there are also functional benefits of endurance training in seniors, as seen with the increase in walking distance. This is also a significant finding because reduction in walking speed is frequently seen in Alzheimer's, which can lead to progressive loss of functional autonomy and independency. So in the future, the authors recommended for studies to consider potential confounders and modulators of plasma BDNF production, such as the genetic variants. Let's take a look at our final study. This randomized control trial assessed the effects of a community-based home exercise program designed specifically for people with dementia in order to improve their functional ability. So there were 40 participants total, 16 of them were men, 24 of them were women, and they had to be community dwelling, which means living either in informal care or having a caregiver who could visit them on a daily basis. The average age, similar to the previous study, was 74 years, with the oldest individual being 89. The control group received their standard usual care with no changes, and their exercise group received a 4-month exercise intervention based on the Home Support Exercise Program for the Frail Elderly. This program was developed by the Canadian Centre for Activity and Aging. This study was adapted for use with dementia by a hospital rehab physiotherapist on the research team. It incorporates 10 simple exercises with 3 progressively challenging levels. So these exercises focus on upper and lower body strength, balance training, and even includes 30 minutes of brisk walking to get that cardio. The participants were asked to exercise daily, and both the participant and the caregiver were trained in the exercise program and provided with an exercise manual that had descriptions and illustrations of each exercise so that they could be educated. So this study assessed cognitive and physical functioning, which included balance, mobility, and lower body strength, activities of daily living, depression, and global functional change at baseline, and then again 4 months post-intervention. The study also measured participant height, weight, and waist and hip circumferences. So cognitive function, similar to the previous study, was measured by MMSE and the Alzheimer's Disease Assessment Scale. Balance was measured with a functional reach test. Basic functional mobility was measured with a timed up and go test, which records the amount of time taken to stand up from a standard armchair, walk 3 meters, turn, walk back, and sit down again. Lower body functioning was measured with sit to stand test, which measures the number of chair rises in a 10-second period. Activities of daily living were measured with the Barthel Index and Instrumental Activities of Daily Living Assessment, and the depression was rated on a geriatric depression scale. So let's take a look at the results. First, I want to go over the limitations. The study found it difficult to establish if the results were from the physical activity program itself or from the social aspects of exercising with the caregiver. This is important because social interventions may be effective in reducing some of the symptoms of dementia. Therefore, more studies are needed to use control interventions with a comparable social component. The study was also not double-blinded, so although the outcome assessor was blinded, the participants and the caregivers were aware of if they were in the exercise group or not. So this could have led to an expectation of improvement by those who exercised and an expectation of decline by those who didn't. The intervention and follow-up periods were also pretty short. They were only 4 months each, so a longer trial would be beneficial to see if the short-term benefits were maintained. And more research would be needed with larger trials over more time to assess the impact on health and well-being. So as far as the results go, there was improvement in exercise group was seen in nearly all functional domains compared to the control. So the cognitive function increased MMSE scores, physical function improved for exercise group compared to the control group, meaning they had better balance, improved mobility, increased lower body strength, and increased independence in ADL and instrumental ADL scores as well. They also had reduced waist to hip ratio compared to the control, but no significant difference in BMI. There was a trend towards improvement for those who exercised on measures of depression and caregiver burden, but these were not statistically significant. So, these results suggest that a community-based exercise program specifically developed for people with Alzheimer's is effective in improving functional ability and improving cognitive and physical functioning and independence in activities of daily living. So this slowing of overall functional decline is critical in supporting both the person with dementia and their informal caregivers in the community. Improving functional ability benefits the individual and their informal caregiver, as well as health and long-term care systems. So, what did we learn? Exercise appears to have potential benefits on those diagnosed with Alzheimer's disease, including improvement in cognitive function and a slower decline in activities of daily living. Community-based exercise programs specifically can improve functional ability, including cognitive and physical function, and independence in activities of daily living. Training also improves aerobic fitness and functional capacities, which indicates an increased maintenance of functional independence to perform activities of daily living. Additionally, no significant plasma BDNF response to continuous or interval exercise training has been found, and no significant improvement in cognitive performance was found without the social aspect of exercise. We also learned that continuous aerobic training is beneficial for quality of life in seniors, indicating a key role of aerobic training to favor social interaction and improve mood and self-esteem. What's next? Well, we've seen that community-based exercise has the potential to positively impact the nature of this disease and the future of treatment. Clearly, more research needs to be done with the actual effects of exercise on this disease, but encouraging community-based exercise seems like a great start. Thank you for listening.